Good morning, everyone. Thank you very much, Alison, for the invite. Delighted to be here. In the interest of time, I am going to skip through some of the slides in my presentation. Thankfully, Professor Flegel has actually introduced a lot of the methods that I'll be talking about. So in terms of the language and terminology, you'll be already familiar having listened to Professor Flegel's talk. So just to kick off then, I have no conflict of interest in relation to this presentation. So I'm going to talk about application of molecular techniques in the clinical laboratory, and as Dr. O'Donoghue has just explained, the molecular biology and genetics department in the IBTS is composed of the National Histocompatibility and Immunogenetics Reference Laboratory, originally and commonly referred to as the HLA laboratory for the reason that we perform HLA typing. The laboratory was originally set up to facilitate stem cell transplant programs for the Adult Centre in St James's Hospital and the Paediatric Centre in Crumlin in Dublin here. And then we have the Irish Unrelated Bone Marrow Registry. So in terms of applying molecular methods, there isn't a one-size-fits-all here. So currently for our stem cell transplant patients and the Unrelated Bone Marrow Registry blood donors, we HLA type all of those by next generation sequencing. So again, that takes a number of days. In certain circumstances, obviously the acute leukemias where it might be a 6 to 8 week period, work up to transplant. There's an emphasis on getting those results through, selecting donors, and then doing the NGS typing again on those donors. Disease association study is a large part of what we do in the HLA laboratory. Not many people will be as familiar with that as the stem cell side. So ankylosing spondylitis associated with HLA-B27, celiac disease, narcolepsy, all have HLA associations. Platelet refractory investigations then. So in terms of patients who are refractory to random pooled platelets, we'll investigate for HLA antibodies. All our apheresis donors are HLA typed for A and B. Then if the patient has those specific antibodies against the platelet antigens, we'll ensure that we select the apheresis donors based on the antigens matching. So we also do neonatal albumin thrombocytopenia investigations, where again, all our platelet apheresis donors are human platelet antigen typed. So again, on the shelf every day, there will be HPA-1a negative platelets. So the HLA laboratory has been around for decades. I first started in the blood transfusion service in 1998, whereas the blood group genetics laboratory is a far more recent development. Only in the last 5 to 6 years has the blood group genetics laboratory been established. So at the end of the talk, I'll talk a little bit about the fetal RHD screening service that is provided for maternity hospitals nationally. The weak D genotype investigations and RHD, CE, and the red blood cell genotype investigation, obviously Professor Flegel has already gone through that side. So in terms of the molecular suite that we have of instrumentation and testing, so we have PCR, SSP, so sequence-specific primers, and that's for our low-resolution HLA typing. So even back in 1998, we had agarose gel electrophoresis. So in terms of throughput, it's very good for small volume of samples where you're not looking at a significant number of polymorphisms within the genes. So again, that's very straightforward, relatively quick in terms of extract the DNA from the sample, set up your PCR, run the agarose gel, and then effectively do a manual interpretation. We then have our sequence-specific oligonucleotide probe assay, so that's what we refer to as our low-resolution HLA typing method. We use this for our apheresis platelet donors, confirmatory HLA typing for transplant patients. So in this instance, again, probes target specific polymorphisms, and that gives us effectively an antigen level. So back again, 1998, we were doing serological investigations for our class 1 HLA typing. By 2001, we'd moved to molecular typing for HLA class 1 and class 2. We had an intervening period where we used Sanger sequencing, and we've skipped through on to the next generation sequencing, so massively parallel sequencing for next generation. So huge amount of data comes off the next generation sequencing. We now look at 11 HLA genes at the same time. We can run 24, 48, 96 different individuals and type them for those 11 HLA loci all at the same time. So as you can imagine, it takes a number of days to set up the reactions. It takes another 26 hours to run the actual next-generation sequencing platform. And then after that, there's a significant amount of time spent with the software analysis and interpretation. So as we've moved forward with molecular methods, we have generated a massive amount more data that is available to us in terms of information regarding the actual gene sequences themselves. And obviously for the stem cell transplant program, that level of detail is what we're looking for in terms of getting the best match between the donor and the patient. And then the final new addition in terms of the fetal RHD screening is we do quantitative PCR, qPCR for the fetal RHD screening. So these are the slides I'm just going to move quickly through in terms of HLA molecules. Most of us are familiar. For anyone who wants to know more, I'm available over the next 2 days to have a chat through HLA with you. So not only do we have 11 HLA loci that we now look at, there's also maternal and paternal. So we've got double the amount of gene sequences that we have to interpret, analyze, and resolve any ambiguities that will be thrown up there. Again, back in 1998, there were less than 1,000 documented alleles, and now there are over 35,000. So again, all this information and more alleles are being identified all the time. So again, the complexity that's involved there in terms of identifying that best match for your stem cell transplant patient. This is deliberately confusing slide. On the left-hand column, you have your NGS result where you have HLA class 1, where it's nice and allelic level for your A, B, C, and then for your class 2, DR, DQ, and DP. The SSO is what is referred to as the low resolution, and as you can see, there are so many variants occupied within that low resolution that you can't even make them out on a slide this size. So, you know, that's where we've come from in terms of antigen low resolution typing all the way through to the NGS allelic side of things. So the 3 applications that I wanted to talk to you about, not stem cell transplantation, but we have metastatic uveal melanoma, acute severe hepatitis of unknown etiology, which is non-ATE hepatitis in children. Some of you may be familiar with those cases that have been highlighted in the media this year, and then the fetal RHD screening service. So metastatic uveal melanoma, it's an aggressive form of melanoma which affects the eye. Uveal melanoma is the most common intraocular malignancy in adults, representing 3 to 5% of all melanomas. In Ireland, we have approximately 1,100 new cases of melanoma a year, so we would expect 33 to 55 cases of uveal melanoma each year. It metastasizes in 50% of cases, and of those 50%, there's a 1-year overall survival of 50% in patients with metastatic disease. So it is very aggressive, and in terms of detecting it, it is usually detected quite late on as well. So previously, no approved treatment until Kimmtrak, which is tebentafusp. So how does that involve HLA, and what have we got to do with that? So tebentafusp is a bispecific protein consisting of an affinity-enhanced HLA A0201 restricted T cell receptor that is specific for the glycoprotein 100 peptide, and that's the peptide sequence there. So A0201 is our high resolution, so we would do next generation sequencing in order to determine this. So again, just to put that in image format, so this paper by Nathan et al. Was published in September 2021. So what we can see here, so we have our uveal tract here. So the melanoma occurs in the iris, the ciliary body, or the choroid. So we have your melanoma cell, your peptide HLA-A2 complex with your GP100, so that's the peptide being presented. The tebentafusp then is specific for this complex. It has an anti-CD3 effector piece on the end of it here. So therefore you have your T cells, CD3 positive, bind onto this, and then you get your cytokine release that resolve the melanoma cell. So that's the theory behind it. In terms of the actual clinical study, what we can see is that with the tebentafusp group, the 1-year survival has increased to, well, is 73% as opposed to the control group who were on one of 3 different medications, whereas at 59%. So if we look at even at 24 months, you have about a 20% survival in the control group and a 40% with the tebentafusp group. So again, since September 21, so from October to October 22, we've received 30 samples on patients with uveal melanoma. And these are our findings. So out of the 38 of them had A0201. So if we look at the comparison between the Irish blood donor population, where A0201 would be present in 43.6% of individuals. In our patient cohort, that was actually only 26.7%. The other A0101 and A0301 are here just to give you a comparison of frequency. So A0101, 44.8%, and in the patient group it would be 43.3%, so pretty much in line. And then the opposite way around for O301, where it's lower in the blood donor population and higher in the patient. But as I said, it's only a cohort of 30 patients that we've looked at over the last year. So the second piece then is acute severe hepatitis of unknown etiology in children. So like I said, you may be aware of this in the media and so on. So there's a dramatic increase in cases that was first reported in Scotland at the start of the year, being at least 3 times higher than the 5-year baseline. From that study then, a follow-up study of 9 of the early cases revealed that adeno-associated virus, AAV2, was detected in 9 out of the 9 cases. Again, from the HLA side of things, how is this relevant? So out of the cases, the 9 cases, 8 of those had DRB1, class 2, DRB1 0401, and the other case had DRB1 0407. So their conclusion at the time was that acute non-AATE pediatric hepatitis is associated with the presence of AAV2 infection, which could represent a primary pathogen or a useful biomarker of recent adenovirus or herpes 6b infection. So there's a lot of theories and ideas about these cases of hepatitis, what's behind them. One would be that the AAV2 infection needs a helper virus, whether it's adenovirus or herpes virus, in order to have this hepatitis developing in the children. So again, just to show you where the cases occurred. So on the x-axis here, we have weeks of the year. So just to highlight, between week 12 of this year and week 18, they're sort of looking at 30 to 40 cases in the European region. This is as of the 27th of October this year, so 563 cases in 22 countries in the European region. So as you can see, it peaked between weeks 12 to 18 and has now reduced in cases. So in terms of those sort of figures, what we're seeing is that the majority under 5 years of age, 7 deaths associated with it, 27% required admission to intensive care, and then of those where information were available, we had nearly 80% requiring a liver transplant. And then again, from the adenovirus piece, about 52.5% of those that were tested had adenovirus. In the Irish cohort then, so along with the National Paediatric Liver Service in Crumlin, they collected 27 samples between January and August. That's actually, we're looking at 40 in total at this stage. So the majority of cases previously healthy, but the median age, 3 years and 11 months. 78% positive for either adenovirus or the herpes virus. And then in terms of those requiring transplant, 2 of those required liver transplant. So again, around that 7 to 8% requiring liver transplantation. In our own population then, so specifically looking at, from the 27, looking at those that were Northwest European Caucasoid, by next generation sequencing, we identified 0401 in 14 of 18, so 78%, as compared to the frequency in the Irish blood donor population of 20%, so 4 times that. And then similarly for 0407, 11% in the cases, and then the normal population, you'd have a frequency of 2.4%. So as an update to the poster that you'll be able to see as well, we now have 22 cases of Northwest European Caucasoid ethnicity, and of those 22, 19 either have 0401 or 0407. Just in terms of the DQA and DQB, this is the haplotype where you have DRB1 040101, DQA 030301, and DQB 0301. So most of them fit in with that haplotype. However, there are 3 cases where you have your 040101, but you don't then have that DQA and DQB association there. So a very strong association with the hepatitis that we're seeing. So finally, just a third example here of the services that we provide. Hemolytic disease of the fetus and newborn, HDFN. So essentially what we're looking at is occurs in RSD negative women carrying an RSD positive fetus. If approximately 40% of pregnant RSD negative women carry a negative baby, therefore they do not need anti-D immunoglobulin during their pregnancy. So by providing this fetal screening service, about 40% of women do not require that anti-D prophylaxis. So in terms of what we're looking at cell-free fetal DNA. So again, cell-free fetal DNA, a great source potentially for non-invasive testing. So what we have here is just a peripheral blood sample from the woman, extract the cell-free fetal DNA, then the genotyping relies on effectively the detection of fetal allele. So in the woman who's RHD negative, not having the RHD gene, and then if there is an RHD gene positive fetus, then by qPCR, amplifying exon 7 to 10 of the RHD gene, we'll be able to detect that. So again, using a flow system, qPCR, positive fetus, we do in triplicate the amplification, so 3 positives will determine as a positive. The negative is here. We require all 3 to be positive. We had previously experienced where we had 2 positive and it actually was negative. So we went with the full 3 to be positive in order to cause the positive fetus. And it also detects maternal RHD variants at the same time. So in terms of our numbers since setting up the service, so in 2019, 1,300, and 2020, 1,700, 21. And then 2022, we're looking at 4,000. So we have 8 of the maternity hospitals nationally sending samples to us for fetal RHD screening. And we hope to have more of those coming on board and providing a truly national service for this. And I'm sure you can see the benefit that it provides. Again, in terms of RHD positive fetus, it fits very well year in, year out, 60%, and RHD negative being, thereabouts at the 60%. So I hope I have caught up a little bit on time. And just to say, these are the guys who do all the work. So big thanks to them. And thank you very much.